Hello and welcome to the American Society of Regional Anesthesia and Pain podcast, ASRA Wrap. I'm your host, Raj Gupta, coming to you from Nashville, Tennessee. And I'm really excited to have a great group of guests with me today to talk about a really special part of the American Society of Regional Anesthesia and a real important part of pain management in general. So before we get to that, though, I do want to make a couple of announcements as far as things coming up for the Society and important events and dates that you should be aware of. So I'm going to show you a couple of things here. So first off, we have this chronic postoperative pain symposium coming up very soon. It's going to be coming up in March. And I do want you to be aware of that because you can register. It's Saturday, March 11th from 9 a.m. to 4 p.m. It is a full program about postoperative and perioperative pain and what we can do as physicians, both in the acute and chronic pain and transitional pain arena to help with that in our practices. I think you'll be really astonished with how good the program is and the faculty. It is a full day, including some virtual workshops that you can actually see how to do certain procedures, and they've got some great recordings and some interactivity involved there. You can go to this website at asra.com and sign up for the webinar, and I think that you will really enjoy this. This is available for CME, so that's an important part of this. Second is our ASRA spring meeting. That's coming up in April 20th through the 22nd. It's going to be in Hollywood, Florida. That's right between Fort Lauderdale and Miami, Florida. So it's two different airports you can fly into. They're very close, 20, 30 minutes to the hotel. And Steve Haskins is hosting this, is the chair of this meeting. He's put together an amazing program, lots of really new and innovative stuff, focus on point-of-care ultrasound, some interesting thing with fluoroscopy for acute pain procedures. I think you're going to be blown away by the content that's going to be at this meeting. So make sure you go and register right now. Two important things to remember when you register. Get your hotel rooms. Those things sell out. So you want to make sure you register for your hotel room as soon as possible before you lose that opportunity. There are other hotels in the area, but you get that great meeting rate when you can register early. Second is there is an early bird deadline, February 23rd. If you register by February 23rd, no matter what class of member you are, what grade of member you are, you will get a discount on your ticket price. So I encourage you to go to the website at asra.com, register for the meeting by February 23rd. You'll save some money, sign up for the workshops, get your hotel room, and I will see you in Florida. I think that's going to be a great meeting. I'm so excited about it. And then that is just two of the upcoming events. There are so many different online and in-person events that the Society puts together throughout the year, and it just goes on and on and on. So I encourage you to go to the upcoming events for asra.com and look at all the different things that are available. Some are free, some are online, some are in person. There's all different types for different type of people. So make sure you go to that website and check all of that stuff out. Okay. So now I've done the announcements. I do want to bring our guests on. I'm going to bring them up on the screen here, and I'll do a couple of introductions. Hello, welcome.
Thank you. Thanks for having us.
All right, so I'm going to go down the list here and do some intros. First, we have Martha Bentley-McLachlan. She's an oncology nursing coordinator for the Division of Pain at the Roswell Park Comprehensive Cancer Center. The focus of her care has been chronic cancer-related pain and symptom management. She's one of the founding members of the special interest group that we're going to be talking about and serves as one of the CME co-liaisons. She's lectured at the ASRA Pain Medicine Fall Meeting under the NP/PA and Nurse program. Welcome, Martha. Good to have you here.
Oh, thank you very much. It's good to be here.
Next up, we have Jennifer Is it Grimer or Grimmer?
Grimmer.
Jennifer is a nurse practitioner in the Division of Pain at the Roswell Park Comprehensive Cancer Center in Buffalo, and she has a focus on chronic cancer-related pain as well. Her education was completed at State University of New York at Buffalo, and Dr. Grimmer is one of the founding members of the special interest groups and serves as one of the CME co-liaisons as well. She has lectured locally, nationally on chronic pain, including at our ASRA pain medicine meetings in the fall. Welcome, Jen. How are you?
Great. How are you? Thank you so
I
much.
was talking to you guys earlier about the snow that you're getting dumped over there in Buffalo. So just be careful up there as you guys are leaving work today.
Thank you.
We actually saw the sun today. It was quite nice.
And third, we have Olu. I'm going to say this wrong, so help me out here. Oluwatobi Hunter.
No, that's perfect.
Did I get it right?
Yeah.
Okay. And you go by Toby?
Mm-hmm.
All right. Toby Hunter is the lead nurse practitioner for perioperative pain management and the co-director of the transitional pain service at the VA Palo Alto Healthcare System. Her clinical interests include perioperative pain management, opioid stewardship, inpatient buprenorphine initiation, harm reduction, and complementary and alternative medicine. Dr. Hunter is certified in battlefield acupuncture and remains engaged in scholarship through peer-reviewed publications, webcasts, and local and national speaking and training opportunities. She's currently serving as the Special Interest Group webcast liaison, which is a perfect place to have you on here because this is a version of a webcast. Welcome, Toby. Thanks for coming.
Thank you for having me.
So we may get one other guest. I'll introduce her if she's able to join us. Our timing was off by just a little bit, but we'll get to her if she's able to join. But I do want to emphasize at the beginning of this that there is a special interest group within the Society of Azra Pain Medicine, which is focused on nurse practitioners, physician assistants, nurses, in pain management. And we mean that in the broad sense of pain management, not just chronic pain, but transitional pain, acute pain, all of those categories. And you guys are members of that, obviously, and has been a very vocal and active group within the society and grown quite a bit in the last few years. Do you guys want to talk briefly about the special interest group, and then we'll talk about the topic of the role of physician extenders in the pain management field? Jen, why don't I start with you? Talk to me a little bit about that special interest group and what you guys are hoping to achieve with that.
Sure. So our special interest group started, we first met back in 2015 when Dr. DeLeon brought Martha and I to our first AZRA meeting. And we are co-founders of the special interest group. So we've grown since then. Our members of the SIG have more than doubled, which is very exciting. We've been able to network with Toby and some other APPs and nurses. And our vision is really to bring together as many APPs and nurses as we can to network and grow as a group of colleagues to support one another. And
Martha, you want to, and yeah, what are you guys hoping for to come out of the special interest group in this society?
For me, I think about how I even got involved, which was Dr. DeLeon, and he brought us together at Roswell. I'm the first nurse coordinator for a clinic at Roswell Park under Dr. DeLeon, and since that encouragement through him, I see now that there's 22 of the nurse coordinators at our hospital, and how much they're helping each discipline throughout the hospital. So I feel like if we could spread that information about how important nurses are to these kinds of teams to help how medicine is changing, how it's so fast paced, is getting nurses in there to help your pain clinics or any type of clinic to support them best. And I think we see a lot of support through, or it helps the physicians with their patient satisfaction, the continuity of care. What do you think?
I would agree. I think bringing that continuity piece in has really been huge for us with physician extenders and nursing staff.
Toby, when you guys, I don't know how long your nurse practitioner PA programs have been present at the VA over there. How has that been growing that? Has it been hard to add physician extenders to your program, or has that been readily accepted? Because I imagine that there's places where they're not utilized at all, or it seems financially insurmountable to try to add personnel like that. But can you speak to a little bit about how you guys have gone about that in your institution?
For sure. So I work at the Veterans Hospital in Palo Alto, and so our financial model is a little different from other facilities, private and public hospitals. But we've been able to we recently added a lot of staff, NP and nursing staff, to our pain group, mainly through the VA's mission to increase safe opioid prescribing in our veteran population. So for those who are familiar or unfamiliar with veterans, one of the biggest issues we have is chronic pain and various substance use disorders and number of mental health conditions. And so the VA is really focused on safe opioid prescribing. And so we actually had an influx of funding, and we were able to leverage that funding to increase our nursing and NP staff, which has been really beneficial because it's helped us grow some of our services and increase patient access to care, particularly through our transitional pain team.
And we're going to come back to the transitional pain team in a second. One thing for Martha and Jen, you guys talked about Dr. De Leon and getting involved with the society. How do you feel like our society is important to other APPs that are out there in practice? What kind of education, you mentioned networking already, but what other kinds of skills could they come pick up by joining the society, being part of the society, being part of the special interest group? Specifically, I'm thinking about people who are now introducing physician extenders to their practice, and maybe they don't know exactly how to utilize them most effectively. The nurse practitioners and PAs maybe don't know how to utilize themselves most effectively in that environment. Where do you guys feel like there's resources for that?
I actually feel like we have a lot to offer. During the pain medicine track, specifically the annual meeting, we have a track specifically for NPs, PAs, and nurses, a full day educational track. Plus, we do have our meet and greet and our SIG meeting, so that's a good time for all of us to get together, meet and talk and share resources with one another. Plus, we do have resources on our SIG's website with different resources, whether you're a beginning APP or an advanced APP. We try to share as much information as we can with one another. So the society really is a great resource for any skill level of APPs to come in and grow.
Let me introduce our other guest here. This is Zohra Hussaini. Zohra is a board-certified family nurse practitioner specializing in pain management at the University of Kansas Health System Interventional Pain Clinic. She finds professional growth through serving on the board of her local chapter of the American Association of Nurse Practitioners and participating in shared governance on the Opioid Stewardship Committee and Advanced Practice Provider Council at her institution. Zohra stays involved in the pain specialty through speaking and education opportunities locally and nationally, and she serves as the Special Interest Group newsletter liaison. Zohra, welcome. Thanks for joining us.
Hi, thank you so much. Sorry, I was a little bit late.
Hey, Zohra, you might need to check your mic. I'm not sure if it's picking up. Try that now.
Can you hear me?
Yeah, that's a little bit better. Thank you.
Okay, awesome. Yes. How are you guys?
Doing very well. So I'm actually going to throw the next question in your direction. Sorry to just put you right in the fire here at the beginning.
No worries.
So, one of the things that I'm interested in is the onboarding process of getting nurse practitioners involved, getting them into the group, making sure that they're trained properly in a subject matter that maybe they didn't have fully in their educational process. Where does that fit? How do you see that fitting into people's group, and how do you do that for places that may be looking to incorporate APPs?
Yeah, absolutely. I think it's a very pertinent question, and it's very evident that a lot of nurse practitioners, physician assistants, or other specialists in APP roles don't get specialized education training in school, right? So we learn how to do assessments, we learn how to, work with patients in kind of a general format, and we learn a lot about diabetes and hypertension, but there's not specialized education in pain management, whether you're looking at medications to prescribe or assessing for spinal intervention. So it's absolutely important that when you're onboarding, that whoever is bringing someone on, whether you're the only APP in the group or you're one of many, that you have that underlying understanding that sometimes these individuals come with no pain knowledge. So that either is on the job training within your institution or facility, or some type of specialized attendance, through a formalized structure, which I can say there aren't very many of those that exist. We do have, for example, the ASRA pain management track for APPs that can, be attended by a nurse or a nurse practitioner or physician assistant in pain. The downside is with all these specialty organizations that have these training opportunities, there's not a comprehensive, cohesive A to Z, start to finish. So you get a little bit here, you get some information about maybe opioids there, but it's not a comprehensive course that we can attend and actually be certified in. So I think each group should be mindful that there needs to be some level of structured understanding with medications, with assessment, with planning, with what interventions exist and how to identify patients. So these would be, I think, key things for a person in that role that would schedule some type of onboarding, to be aware of, network with our peers in our societies, in different institutions that can help build or create that structure. It's never, I would say, perfect. Like, I don't know that any organization that said we have a great onboarding and our AVPs just get right into it. I think there's always a struggle. There's always a little bit of a learning curve, but I think it's a very important topic. And so hopefully through time and with awareness, we can get more educational opportunities for APPs, specifically in pain.
Sounds like there's an opportunity for a curriculum development that is either through the Society and Special Interest Group or some other format, even just a consolidated reading list of materials. Seems like there's still a need for that, especially as the growth of APPs happen across the pain spectrum. Maybe a to-do list item that we can think about for the future. So
yeah, absolutely. Curriculum sounds great. It doesn't currently exist, so any collaborative effort towards something like that, I think, would be excellent.
I know there's been a lot of interest on the physician side to go, and our society has been actively working on this, to actually go and generate curriculum based on stuff that we've put together at meetings. So we have curricula, like you said, it's a little disjointed, but it's high quality, and put that all together into a package and actually send it to medical schools, because medical schools have the same problem where their pain education curriculum is often thin depending on where you go to school. And so people get either outdated information or they get a very, very cursory information. And our perspective is not towards the pain physician, but the people that are going to be non-pain physicians. Like, they should have a better baseline education, so that when they're dialoguing with us, that it's more understanding of the full spectrum of opportunities for patients' pain management. Often, people think it's opioids or not, it's black or white. It's, but this, as you guys are well aware, there's a whole host of options available to people, both within pharmaceuticals and then also procedural options.
Right.
So, maybe something that mimics that for the advanced nursing education, that might be an interesting thing. I got a comment from one of my colleagues, a nurse practitioner that works at my institution, Jennifer Jairam. She asked the question, are any of you working in teaching services? Can you comment on the interaction of your teams between, I'm assuming that means, I think the rest of her comment got cut off, residents and APPs, and then also APPs, PAs, and CRNAs. Do you guys have those kinds of interactions that you deal with?
Yes. So before I answer that question, I just want to piggyback off of Zohra. So one of the first webcasts that we published is actually a webcast that goes over APP onboarding. So for folks who are looking for some guidance on how to onboard their new APPs, they should check out that website. Provides some pretty good information while we wait for something more structured.
Is that within the special interest group page?
Yeah, it's on the NPPA RN SIG webcast.
Let me see if I can find that while you're talking. Yeah, go ahead. Keep going about the other question too.
So yeah, my group, we are a teaching facility. My daily, our acute pain service includes an attending, a fellow, an NP, and we have a lot of anesthesia residents, surgical residents, the list goes on. We don't have any CRNAs, but I think generally speaking, the culture at the VA is very collegial to begin with. And so we generally don't have any challenges collaborating with other services. And as far as our facility and our structure, we have, long before I even joined this team, established a workflow where the acute pain service manages the pain for some of our surgical services. Like, we manage post-op pain for all of our ortho post-ops and neurosurg patients. And so it's kind of understood and it's very collaborative. And usually by the time they're consulting us, they're pretty willing to go with our recommendations because the surgical services have tried everything they know to try. And so by the time we get involved, they're just like, please help us. And so we don't really have any challenges with our APPs working with residents and other trainees.
Jen and Martha, do you guys also share similar experiences, or you guys have a different setup?
We do. We have 2 fellows, and then we have monthly residents. We have an intern and a resident who rotate every month through our service. Plus myself as the nurse practitioner, Martha is our oncology nurse coordinator. So we do a lot of teaching.
We do a lot of teaching to the new people that come through on a monthly basis. So Dr. DeLeon runs a fellowship here, like Jen said. So there's 2 fellows a year. And then the anesthesia team, they send all their residents and interns through. So, which is a good support to learning, the information behind pain management. And as the nurse there, for me, I do all the teaching to all the new patients. I think that's an added bonus to the clinic is they get the RN teaching when the doctor can get out of the room once they put the plan together. I have a phone program where I follow up on the patients to make sure they're doing okay. And just we've developed a telephone service where the patients can call when they have questions or concerns.
Yeah, I think we really have a great team structure. It works well. And I think the residents and interns and fellows pick up a lot by the teaching that's provided in the clinic.
So Jen has a follow-up question. She says, we've had difficulty getting surgical resident leaders to allow surgery residents to rotate with us on the pain service. She's specifically talking about acute pain. And we only have anesthesia residents on our service. Did you guys have any success engaging with surgical residency programs so that they can be better informed about pain management, even though they may not be practicing it in the same way as we are?
We sort of have a similar issue with the surgical, but as each year goes by, it seems like we're getting more buy-in, and then but it's still they have to request the time to spend with us, which we will never turn down. But I really feel that it should be made as a mandated that these surgical residents are coming through, because you see the need from once we do take care of them in the inpatient setting after surgery,
or even when to consult the chronic pain services, like when to send them there instead of letting it linger for longer and longer. There may be interventions that are available earlier in the process.
I do see it happening more and more, but I know more work needs to be put into that too. So,
yeah.
I think one thing I would add to that too is if your team, like your physician team and your group, if you can voice kind of what you see as maybe an issue, then they can work towards a collaborative, maybe in servicing or just connecting and communicating. We work in a larger kind of institutional setting, hospital setting, so it's maybe a little bit different than a private, setting. But if you're kind of in that realm where you're doing surgical treatments and you have residents and are in that setting, you have more, I think, opportunity to connect with your surgical, neurosurgery, orthosurgery, whoever it is, or even gen surgery to say, here's what we can offer. Here's what we would like to be able to help with. Please let us know. And then if you have patients you've actually treated, like just referring that information back to say, here's what we've done. The patient might be doing better, so they see that. So I think it's just recognizing the opportunity and then talking to your team to see how you can make a better approach to what's going on that might not be working so well.
I think it's always valuable if the people that you're working with have an opportunity to directly see the other perspective. Future conversations become more collegial, more productive, and less confrontational, or where there's not full understanding of the why, or at least a direct identification of why the service behaves the way it does, or why they make the choices that we do. Many of our APPs in our acute pain side have worked in surgical services in the past, and so they do know that side of the challenges and the demands that they have to face, and so that helps us a lot in our communication and maintaining that collegiality. We'd love to have some of the surgery residents come join us, either on the chronic pain side or the acute pain side, but unfortunately we haven't had a lot of luck getting them involved with that at our institution. I don't know if anywhere really has. To go back to one of your other comments, Toby, you talked about the webcast. I'm going to put it up on the screen. This is the SIG website. Under their resource center, there's several webcasts that you guys have, and I think this is the one that you were talking about, recommendations for new hire onboarding.
Yes.
For those of you guys watching, in the comments, I put the link directly to it. This is the link. It's too long to copy off your screen, but it should be in the comments that you can copy and paste from there. So that's a great, and that's not one resource. There's several videos that you guys have put on the website that are useful resources, including treatment of pain and acupuncture for pain and addiction, intravenous ketamine, opioids, buprenorphine management. So very high level and current topics on pain management. Toby, I want to jump to you for a little bit. We talked a little bit about the acute pain side. I want to talk a little bit about this transitional process. That's something that's very, at Vanderbilt where we are, there's a lot of energy being put on this because we noticed a huge gap. What is your role in your transitional pain service? And I know that you guys are really actively involved there at the VA. Somebody's got a siren in the back.
Sorry.
That's okay. So we do work at hospitals. It's all right to have sirens in the back. So tell me about your transitional pain service and what your role as APPs are on that, and how that adds value to that service that can often be a very tumultuous service to maintain.
Yeah. So our transitional pain service started in January 2020. We didn't have any funding. And, we were trying to get funding, and then we just decided, let's start with what we have, and then hopefully we'll get funding. And so I started this in June 2020, and we started with the low-hanging fruit, which was our orthopedic surgery service. And I say low-hanging fruit because we already had a really great working relationship with them. As I mentioned, we already collaborate with them regularly on the acute pain side. So we thought it would be easier to just kind of roll their patients into the transitional pain. And as the nurse practitioner on that service, it was really beneficial to have that as a primarily NP ran service, because you just have really great continuity of care. These patients need really close follow-up. And so, you're calling these patients every 7 days. You're getting secure messages and calls for them throughout the week. And the fact is that my collaborating physicians, anesthesiologists, they're in the OR, they're, doing procedures. They don't have as much flexibility and availability in their schedule as I do to, be as accessible to the patients. And I think that's where the role of the NP and even the RN nurse coordinator really comes in and shines. We increase patient access to, specialty care.
That's such an important word that you said at the end there, is access. I mean, I think there's so many patients that feel lost in between being in the hospital and, even their 2-week follow-up with the surgeon or something like that, that the system often loses them. There's not a good point person, particularly with pain control, and nobody really wants to be responsible for it. And so having a touch point that's consistent, reliable, that's a huge service to the patients. And if not, even if they don't use it, it's just an anxiety reducer to know that somebody's going to answer that phone call or be available to answer those needs. So we've definitely noticed that gap, that everybody sort of fills in outside of their normal responsibilities, but we don't necessarily have the bandwidth to do that all the time without creating a separate structure like you guys did over there. And Jen and Martha, you guys work in the cancer clinic, so you guys are crossing both inpatient and outpatient. Cancer for the longest time has been a philosophy of, it doesn't matter how much opioids you give, this is cancer. Cancer patients can get us whatever they want. And there's been a very, very liberal mentality of giving opioids to cancer patients for a long time. Again, you guys as APPs provide constancy on the service where a lot of the physicians will rotate through. How have you guys seen that transition happen from the sort of permissive nature of opioid prescribing in cancer pain to what it is now? Hopefully not permissive nature.
It's changed so much.
I find it's changed dramatically.
So much. Yeah. I started, go ahead. You can.
Well, no, I was just thinking, I started here as a nurse on a surgical floor. So I've been at Roswell for 30 years, and I came to the pain team 15 years ago. So I left a group of people that I mean, they were good prescribing, but I used to think, oh my God, why would you give that much pain med to that person? And, you know, coming into this area and learning a lot of different things that, you know, opioids aren't the only answer to their pains. And, you know, just supporting the patients with, you know, solid teaching of the medications and you know, the different meds that can be used and the teaching you can provide those patients.
Yeah.
I noticed a huge difference over the years, how better it is under this kind of, you know, routine with a pain management team.
I would agree. I mean, even just in starting with pain team, I did bone marrow transplant before pain management, but the prescribing practices were completely different, not, you know, before coming to pain. But from 2015 till now, even the way we do opioid prescribing has changed in the chronic pain setting. We're using more adjuvants, not that we didn't before, but I think we have certainly changed prescribing practices. I think it is critical to really have that pain diagnosis. It's not always just cancer pain. There's so many components to the cancer pain at hand, and taking into account that whole person that you're treating, not just the disease. It's complex. I think that's the best way to say it is it's just become more complex.
Yeah, I spent many years doing a pain. It was a half-day pain talk with a nurse residency program that we have for RNs that are trying to get some advanced learning. And so I was the physician lead on that education program, and one of the other people on the education panel was a nurse practitioner in the cancer clinic. And it was interesting. I remember very early on, the philosophy in the cancer clinic was very different about pain management than it was where I spend most of my time in acute pain trying to avoid opioids on people. There was a very open philosophy of pain opioid use in those cancer patients. And I spent about 10 years working with her on this class, doing it every quarter. And you know, it changed in her practice too. That she saw a big difference. They were also dealing with sickle cell patients, so that same problem in sickle cell patients. They have that same issue where it gets some very permissive opioid prescribing. So it's interesting that education over time is kind of spreading, and people are seeing the value of doing some of these other treatments. And I think now they're doing buprenorphine more often. They're doing ketamine infusions in the clinic. They're doing more interventions for people with even terminal cancer diagnoses to reduce pain, ablations of various kinds. So there are a lot of options that open up once you start getting off the conversation of just opioids.
Yeah,
absolutely.
Zohra, one of the things that is really hard for people is whether they should hire an RN or an NP for their service. You know, I have my own feelings because I've had the privilege of working with some fantastic APPs and RNs in my environment. But and I'm going to guess that you're going to be biased in this answer. But thoughts on the value add? So that's the hard question for a lot of people. You know, it may seem expensive on the front end. What do you see as the value add for physician extenders?
You know, yes, I will be biased. I think we're a great addition to the team. In any team, I don't think pain management is exclusive, and it's been, you know, there's just been a huge burst of people in the role, and a large, you know, hiring of APPs in healthcare in general to fill those gaps where we just don't have enough hands on deck, right, so to speak. Lack of maybe physicians available to fill that role. So then we have a lot of these opportunities for APPs to step in, and as Toby said, it become that access to care, right? So if the value can be seen through optimizing an APP to their full scope to help you in your role, it's a patient win, it's an APP win, it's a physician win, it's an institution win, right? I think the biggest maybe challenge and dilemma is when there is maybe misunderstanding of what that scope of practice is, and we kind of get into that gray area or muddy water of overstepping boundaries or maybe not being fully utilized to their scope to do what they need, and then maybe people aren't as happy or not as functional in their roles. But overall, I think it's evident, and I think there's slowly some actual evidence coming out to show, that there are pros to having increased access to care, availability of patients to be seen more quickly, and to get treatment and care that maybe they otherwise would have waited longer for. In our training, as we get more education and get more skilled and sometimes procedural areas where it is in our scope, to help manage some of these acute needs where patients don't necessarily have to see a physician, and our physicians are more capable of spending that time in the OR or in the procedure area where they're most best utilized at their full scope too. I think helps the patients get what they need, and overall satisfaction is better because they're calling and they're getting to talk to somebody and getting something taken care of rather than waiting or having, some specialists. Even personally, I called the other day to schedule an appointment, and it's like 6 months before you can see somebody. So fortunately, I think we don't have that gap because we have enough practitioners who can see the patient sooner, triage them, get them more immediately what they need, and then to the physician for intervention or treatment or surgery if they need it. So I do think there's evident value. And as long as you partner, you obviously have to have good collaboration, a shared philosophy, trust, good communication with whoever your partner is, whether it's an APP, another physician, a nurse, or whoever's in your team. So as long as you can connect on that level and communicate with them, I think it's a no-brainer that having advanced practice providers, in addition to your nurses, I don't think we're capable of doing anything more without a good team of support staff, and that includes our nurses, our schedulers. So I always tell people I'm only as good as my team. If my team can't help me be as optimal as I can be, then I'm only going to be able to do so much too. So I think it all comes together, with a good physician. If I can't communicate with my physician, if we're not on the same page, I'm not going to be very optimal in my role as well. So yes, we're valuable. So I think it's important that people can see that. There are a lot of physicians who are new to APPs who've never worked with an APP, which to me is surprising. But I also started in my role, a little over a decade ago, and I was the only APP in the space. So I think now we're everywhere, right? NPs, PAs are being optimized. So, but there are a lot of people who still have not had the opportunity, maybe to work with somebody, and they have their biases from, potentially some things that may have been a situation in the past that they had experience with. But I think, collaboration is key. I don't think there's ever a time or a place where anybody should work independent of collaboration, whether you're a physician or an APP. And, there's a lot of, I think the biggest risk or issue that comes up is usually around practice authority within states, especially for NPs. And I think it's not about us working isolatedly of our physician support. It's simply about, us being able to work to our full scope, and we continue to collaborate. So if that mindset can be, bypassed and people can get past that, you know, whatever that idea is that they have about, this full practice being something that we work isolatedly, I think everyone can understand the benefits, hopefully.
Yeah, I think that Toby mentioned earlier access. So much of this collaborative team effort is about improving access to fill a huge need out there. One thing that we are seeing as on the physician side is that there is no shortage of need, and it's growing, particularly in the pain field. We're probably still only touching the tip of the iceberg as far as people who need care. And there's just not going to be enough physicians to go around to do all of that. And we have to think of creative ways of building collaborative teams that can leverage. And I really liked your term scope of practice, leverage people at their full scope of practice to really take advantage of that. It's amazing. We've already gone 40 minutes. And I'd love to give you guys each an opportunity to say one last word. And I will finish off with a reminder for people about the special interest group. But Martha, why don't we start with you? Any last word that you'd like to share with people about the space with APPs and RNs in pain management?
Well, just like Zohra said, I think it's about that teamwork from your attending physicians to the APPs to your residents, fellows, interns, and nurses and schedulers, just like you said. It's just so important. I've watched our team grow and see that it's kind of like a well-oiled machine, and because we've had this continuity for 10 years now, and we all know we can count on each other for certain things, and we know the job is getting done well, and we're giving to all the teams that are the new people coming through, a good education and support, and I think it helps them when they move on too, and you can feel proud of that. So I hope people do see this and think about adding nurses and APPs to their groups. I think it's so important.
Jen?
Yeah, I echo exactly what Martha said. And Zohra, it really is about the collaboration and the teamwork. Without that, I mean, you need that team backing to make the clinic work and to get that patient care and access that you're looking for. I mean, it's truly all about the patient and giving them the excellent care that they deserve. So having that team to support is important. And I can't thank Dr. DeLeon enough for really helping us get to where we are. He's really supported us, and I've grown a lot as a provider thanks to him. So that collaboration has come into great play.
And thanking Azra.
Absolutely, all the resources and support in developing the SIG, and it's been incredible.
Fantastic.
Yeah, I feel very honored to have been part of this so far.
Toby?
Yeah, I mean, I of course piggyback everything that they've said. I think training is really important. Like, I can't emphasize that enough. You can't bring a NP into a specialty role where you guys completed fellowships and expect us to just jump in and get the work done. We have to be trained. And then once you have onboarded and the NP is comfortable and, can practice, you have to also support them in their career development. No one wants to be stagnant. I think it's really important to also work with your NP and their RN, APP with their career development, encouraging them to, seek opportunities, attend ASRA, submit a abstract for poster presentation, network, and then write publications in peer-reviewed journals, and just whatever they can do to grow in their career. I think sometimes NPs, we don't realize the things that we can achieve, but if we have a really supportive, collaborating physician, team members who really encourage us, we can grow professionally, and that will also keep us happy, and we'll work with you longer.
And harder.
And harder.
Zohra, any last thoughts?
Yeah, for sure, piggybacking off of everyone, or I should say,
they already piggybacked off you, so you can't circle. You can't circle all the way back.
I'm not going to say it again. But I think anyone who does know me, I would take any opportunity to always be mindful of if and when physicians or other APPs refer to themselves as a mid-level provider, to stop doing it, right? So I will butt in and I will say, hey, think about what you're saying. Mid-level is not, we don't provide mid-level care. It's an old term. I don't think anybody means ill by it, but, just understanding that there is advanced education and advanced practice that these individuals are providing, and it can start as simple as just providing that little bit of mindfulness or respect or terminology that we sometimes forget because it's been out there for so long. So anytime any of our physicians don't say it anymore, I've been there long enough that they know not to say that, but anytime someone does, I always take opportunity to kind of give them a little bit of a hey, just FYI, it's not the proper term. So even simple things like that, I think, are important. And as Toby said, you stole my thunder, but training is important. If you don't train somebody early on, they're not going to be successful long term. So spending the time, giving them the opportunities, if you know that there's a conference like ASRA that has an APP, RN specialty track, suggest to the APP that you work with, hey, you should attend this. This might be good for you. Or looking for other opportunities for resources for them, including them in meetings and discussions and those types of things, I think go a long way. As well, to keep those individuals part of the team and keep the conversations going and help making sure that your practice is all on the same page. So I appreciate the opportunity to even be here to talk about my experiences. I think we've known each other for a long time, and I think we've all kind of grown together in our roles in the space. It's a growing space. We start to network and learn each other and meet physicians and other EPPs along the way. And it's all about networking and building those connections and those bridges to kind of help ultimately our patients have better outcomes. So appreciate the opportunity and the opportunity for last words, and the girls here as well for their thoughts too.
So, just you hit on the networking part, and so much of what, let's change the word networking to mentorship. A lot of what you're talking about is also mentorship. And so one of the things I love about our society is that we really create infrastructure for mentorship, even if it's just meeting in the hallway, getting to know your guys' faces on this podcast so that when they come to the meeting, they'll be like, oh, I remember listening to Toby talking about transitional pain service at the VA. I'm trying to start up something like that at my VA. How did they make it happen? And maybe somebody will approach you. That's how these things happen. I'm a big believer in that kind of face-to-face interaction as being the starting point of a growing mentorship relationship. And so I hope people do recognize you guys at a future meeting and come up to you and introduce themselves. And that's the start of a great opportunity there. So get involved with the special interest group. For those of you guys who are listening, the PANP-RN special interest group, it's a lot of letters because there's a lot of really active people in that special interest group. It's a really great group of people. It's been focused on chronic pain, but I know there's been more interest in expanding towards the transitional and acute pain side in that group and expanding the scope of conversation within that group. So I highly encourage you to be part of that group. And I'll take a moment of privilege to brag on our own APPs at our institution. I work on the acute pain side, and we have a phenomenal group of people that work with us many of them have been with us for quite some time now. And the leadership that they show on the service has been remarkable and really allowed us to expand the service almost exponentially over time. That definitely would not have happened if they weren't there. So I can attest to the value that they add directly to both patient care, but also expanding the breadth and depth of the service. But as a wrap up, thank you guys, Zohra, Toby, Martha, Jen. I really appreciate your time and talking with me, and I hope people get involved in the special interest group. Go to ASRA.com to find out about upcoming meetings, find out about the special interest group, tap into all those resources that Toby's mentioned that are on the website. A lot of good, enduring content there. But with that, I'll wrap up. Thank you guys. Have a good night. And we'll see you guys soon in person.
Yes, definitely.
Take care.
Thank you.
Thank you.